Okay, so if there are no more questions, we can start the next topic. That is the transfusion medicine services, right? So my screen is visible to all of you.
Yes, sir.
Yes, sir, it is visible.
Okay, so I think it's not in the PPT. Sorry, the presentation form. I'll do it again. I think I have to log out and log in again. Let me do it again.
No problem, sir.
Okay, it's not showing in the full screen, but I'll show you in this form. This should be okay, I guess. So we'll just reduce it and keep it at that.
No problem, sir. No problem, sir.
Okay, okay. It's visible to all of you now?
Yes, sir.
Okay, thank you. So transfusion services, as you all know, is a very important component of a tertiary care hospital and the secondary care hospital. Primary care hospitals usually do not have the transfusion services. Even at the secondary level, CHCs usually do not have it, but the district levels, you will find that they have blood banks, may not have the Department of Transfusion Medicine, but majority of the medical colleges and the larger institutes in this country now have started having separate Department of Transfusion Medicine. Earlier, most of these blood banks were being managed by the faculty of Department of Pathology, and they were looking after the hematology and the transfusion services as well. But over the decades, especially in last 2 decades, the after the implementation of the national blood policy, there is a focus on having a separate Department of Transfusion Medicine in the medical colleges. So the National Blood Policy actually published in 2007. It aims to promote the voluntary, but at the same time, it is more important is safe blood donation, ensure adequate supply of safe blood, regulate blood banking practices. I think someone's microphone is on. I don't know if you can just switch off the microphone. Yeah. Ensure adequate supply of safe blood, regulate blood banking practices, eliminate profiteering in blood transfusion services, and address issues of technical personal research and the development also. Now, what are various categories of blood banks? So there are mainly 3 categories and 4 types. So 3 categories, category 1, 2, and 3. And it is based primarily on the blood consumption and usually the the bed strength. So the blood consumption, if it is 3 to 7 units, it is category 1. If it is 8 to 15 units per bed per year, it's category 2. And more than 15, it is category 3. Usually, if you will see that 3 to 7 units per bed per year is usually in the hospitals having bed strength of 100 to 400. Category 2 is usually the bed strength of 400 to 1000. And the category 3 is usually the bed strength of more than 1000. Blood bank by this scale is of 4 types. Where the consumption is low, bed strength is usually less than 100. We call them type A. Then type B is moderate consumption. Type C and type D is the very high. But usually 1 to 3 is a better categorization. Now, planning consideration from our point of view, as an administrator's point of view, if we are planning a new hospital, and if the hospital is a, let's say, district hospital or a medical college, or even if it is not an academic institution, if it is a standalone hospital, even without an academic attachment, and if we want to plan a blood transfusion center, services, or a department, then what are the things that we need to keep in mind? Always remember that the blood donation area, and preferably, it should be preferably on the ground floor and near to the emergency department. There are challenges also of having the blood transfusion services in the near emergency department, because when you are organizing a blood donation camp on site in your hospital, you need to have sufficient area for that. Or if your bleeding area is small, then you will face problems. So your area, and we'll discuss how much area is needed, is in a way that is not compromising on the emergency department. Have enough parking areas, and the intramural transportation is in a way to the transfusion medicine department, that is, it is not hindering with your routine emergency services. So I have seen many hospitals, including my hospital, that are very well planned, in which the transfusion medicine department's blood collection area or the transfusion area is on the ground floor and very near to the emergency department. It must be of a suitable size, construction, and location. Most must comply with the requirements for the biological substance number 1, and adequate space, lighting, and ventilation is required. Minimum area for category 1 is 100 square meters, for 2 is 300 square meters, and category 3 is 895 square meters. What are the physical facilities that are required? Obviously, a registration and a medical examination room, collection area, component preparation area, laboratory for blood groups or serology, then laboratory for examination of the blood transmissible diseases, sterilization cum washing room, refreshment cum restroom, store rooms, record rooms, counseling room, quality control area, administrative and clerical offices, and if it is a teaching department, then you need to have a seminar room and the associated other teaching areas. Now, not only this, sometimes some of the teaching departments and you might be asked for HLA typing also. Usually it is done by the Department of Pathology. But I have seen in some of the newer aims, the transfusion medicine departments are so good that they are now helping the transplant by doing the HLA cross match and grouping also along with the blood grouping. Physical facilities, hygiene and environment is important. Best hygiene condition must be maintained throughout the premise. All rooms must be easy to clean. Waste collection and disposal must be separate. Potentially infective materials disposed of by the autoclaving or incineration or as per the biomedical waste management guidelines. Blood samples and outdated bloods must not be discharged into the public sewage. You know, blood is very precious. In my view, it should never be allowed to expire. You should collect only the number of units that you have estimated to be used within the shelf life of the blood. So don't be over enthusiastic and collect too many blood, and there is a seasonal variation also. You will find that in some seasons the demand for the healthcare services increases, and during some festival seasons, etc., you will find that patients do not want to opt for the elective surgeries, and then the requirement for the blood during those periods goes down. So as a good administrator or an in charge of the blood bank, or if HOD of the transfusion medicine, you need to be mindful of these variations. Air condition is desirable for donors and staff comfort. Filtered air, low temperature and humidity may be required for some equipment. Now, equipment list is quite large, and depending on the category of the hospital, it may differ from one to another, but usually you require refrigerators, centrifuge, water baths, incubators, hot air ovens, binocular microscope, weighing balance, tube strippers, BP apparatus, pH meter, VDRL agitator, and blood bank stand, test tube racks, marker pencils, blood banks, they're usually of 350 ml to 450 ml per one unit that we call. And depending on what services you are providing, you will require different types of bags. The other equipments are blood center refrigerated centrifuge, freezers, depending on whether you are having components or not. Dielectric tube sealer, plasma separation stand, and there are so many other things that may be required, right? For screening, obviously, you need the ELISA system for washer, incubator, and reader. You need kits for those, transmissible diseases, whether it is HIV, hepatitis B, C, or the syphilis. FRS system, if you are providing the FRS services, additional equipment for center collecting more than 10,000 units might be required. Staffing, this is important, and it is as given in the manual, is that for different categories, different staffing, but what you usually need is an in charge, right? That in charge, depending on the type of hospital, could be a HOD or a MD in transfusion medicine or a MD in pathology, or a medical officer who is designated as a blood safety officer or a blood center in charge, who have sufficient experience or training in managing the blood banks. So a junior doctor, along with that, a junior doctor, nurse, social worker, lab attendant, technical supervisor, technical assistant, lab technician, lab assistant, and lab attendants. And the nomenclature in different hospitals for these category of staff could be different. Policy and procedures. Every blood center must maintain documented standard operating procedures. All staff must strictly adhere to SOPs. You could go for accreditation also for the blood bank. Donor selection and blood collection protect both donor and recipient. Every donor undergo medical history screening and limited physical examination of the day of the donation. Here we usually do in India medical history screening by asking the questions or we can give them a paper to fill. I had an experience of I wanted to donate blood in United States almost 12 years ago, in fact 14 years ago. So they just gave me iPad, and they behind a screen they made me sit there and input your personal information and your history and all that. So no one knows that what you have filled. So when we are asking someone, at least healthcare provider is coming to know about those information, that information. But if you are filling it on your own in an iPad, then no one sees it, and at the end of the your filling of information, the algo will tell you whether you are eligible to donate the blood or you're not eligible to donate the blood. So that is another way to do it. Acceptance of rejection of donor must prioritize donor well-being and recipient safety. The detailed donation criteria and deferral conditions governed by the Drug and Cosmetics Act of 1945 and the rules that have been amended from time to time and recently in 2020. Drug and Cosmetics Act of 1945 is very important from the pharmacy point of view, from the transfusion services point of view, and also now, as I told you, the MRI also is considered under the Drug and Cosmetic Act. So please make yourself aware with the salient features of the Drug and Cosmetics Act. The managerial issues. Blood transfusion medicine has advanced due to progress in immunology, biotechnology, and genetics. Voluntary blood donation emphasized to reduce risks from commercial and paid donors. We always prefer that the donation should be a voluntary donation first. And in only when that is not available, you should go for a replacement donor. And commercial and paid donors are totally banned. So being vigilant, it's very important that the blood bank staff and the in charges are vigilant about it. And we should promote the voluntary blood donation among our healthcare workers, also among our family members, neighbors, society, etc. Blood shelf life is extended from earlier used to be 21 days to almost 49 days. So long-term storage via cryobiology is now possible. Blood component therapy, we have device where we can, segregate different components of the blood, and then we provide those components to specific type of patients for specific indications. Enhanced screening reduces transfusion reactions and disease transmission. Genetic engineering and artificial blood substitutes have been examined, but still they are not the common practice. Transfusion reactions can happen despite best of your SOPs and best of your practices. So it is important that cross match has been done properly, that the recipient has been examined properly for the type of blood to be given. Still it can happen, so monitoring becomes very important. And I'll discuss about the mismatched blood transfusions in the subsequent slides. The organization blood donor recruitment has shifted from individual to the community-based efforts. Shift is from paid to the voluntary donors. Community-based approach is considered the most equitable and effective strategy. If 1% of population donates 1 unit per year, national blood needs are met. Inventory control, as I mentioned, it is important to understand the utilization and the seasonal variations. Minimize blood wastage is crucial. Outdating should be estimated to 10% or less. Computerization and improved communication actually reduces the waste. And regionalized blood transfusion services enhance inventory management, where you can share your blood with others and where it can be utilized. And when you do not have that particular type of blood group, blood for that group, you can actually get the blood from others. Hospital blood transfusion committee is very important, especially in a category 3 and 2 centers, which are the big centers. Committee must meet quarterly as part of the medical audit. Members should include medical director, administrator, blood center chief, and many times you will see that the The medical superintendent is usually the chairman of the committee. Just give me a moment. Okay, so usually the medical director or the medical superintendent is the chair of the hospital blood transfusion committee, but anyone else who has better, control over the system can also be the chairperson. Representatives from clinical departments, both surgical and the medical departments, as well as the diagnostic departments, should be there. Representatives of the nursing staff should be there, and the technical staff of the institute. System audits they should do periodically, review procedures. They are responsible to have the blood transfusion policy for the institute, ensure that the practices are being followed. Then if some reports of errors have been reported, then they do the root cause analysis, and then they give recommendations and help in implementation of those recommendations also. Reduce the turnaround time, reduce the outdating rate, etc., etc. They do the audit for that. And then they do the clinical practice audit, review criteria and justification of transfusion. So the blood transfusion policy of the institute mentions what are the conditions where blood should be, asked to be provided. Then what are the conditions for which you should go for the whole blood, for what are the conditions for which you should go for a component, etc. And it should be an evidence based, and it should be updated based on the new evidence that is being provided to the committee. So there are different types of blood components: packed cells, fresh frozen plasma, which is popularly, or abbreviation that is used is FFP, cryoprecipitates, or the fresh blood. Massive transfusion, many times we prefer for the fresh blood. And then the factors that we provide, individual factors also. Drug and Cosmetics Act 1940, actually we call it now 45, regulates blood and blood component products in India. Blood is classified as a drug under Section 3B, mandates strict safety, quality, and efficacy of standards. Blood centers require licensing from the DCGI, and periodically these licenses are renewed also. Must adhere to rigorous inspection and compliance measures. Regulations govern collection, processing, storage, labeling, and distribution. Authorities is the CDSCO, which is at the central level, and then the district controllers oversee the overall compliance. The key provisions of the Act are classification of the blood and blood products as drug, licensing and regulation, standard for blood and blood products, guidelines for the manufacturing, storage, and distribution of the blood, who are the regulatory authorities, who can do the inspection, what are various blood transfusion services, their safety, ethical standards, regulation of their donation, record keeping and traceability, documentation, recording, ADRs, etc. Penalties in case of violations and the legal actions for the non-compliance, and prioritizing the voluntary donation, etc. For licensing, blood cannot be collected from professional or paid donors. These are some of the things the blood centers need to follow. The license and renewal certificate must be displayed on site and presented on request. Any changes in the technical staff must be reported immediately to the regulatory authorities. Changes in the name of the firm must be reported. License valid up to 3 months until new one is obtained. Blood banks must comply with Drug and Cosmetic Act and guidelines from the National Blood Transfusion Council and the National Blood Policy. Non-compliance in any form could result in penalties or suspension of the license. Key quality control measures that you need to follow this. I think I'll cover in the quality that patient safety. Then when I discuss the next on 18th, so I can just transfusion reactions, quality and patient safety. I will be covering in the patient safety when we discuss the patient safety. But anyways, in short, I can tell you that key aspects are that donor selection is very important, as I mentioned earlier also. The donors, otherwise what will happen if the donor screening is not proper and then you screen that blood and you find out that now it cannot be used, you will have to discard it, and unnecessarily your wastage and the discard rate goes up. During testing and processing, you follow the SOP, labeling and tracking. And let me tell you, most of the errors that happen are happening at the labeling, tracking, and administration level. And it can be prevented at these three places. Storage and handling, the patient safety, correct patient identification. There should always be two identifiers, not just one identifier. Before you administer blood to a patient, you should check for two identifiers. One of them could always be name, but look for other identifier of father's name, husband's name, your registration number, location, home, or any other thing that's there available to you, phone number. So always check for two identifiers for the patient. Monitoring clinical guidelines, staff training, regulatory compliance, and managing the adverse events is important. And adverse events can happen. Sometimes serious adverse events can also happen. For example, in the form of some hemolytic anemia, if the reaction happen because of some incompatibility. Hemovigilance, it's a national program of hemovigilance. It's basically surveillance of the system that detects, reports, and prevents transfusion-related risks, ensure patient safety through the transfusion process from donor to recipient. We are concerned about for both the safety of the donor also we are concerned. So that's why screening is important. So it's called HVPI, that is the Hemovigilance Program of India, launched in 2012, managed by the National Institute of Biologicals and the Ministry of Health. And it is a joint international hemovigilance network in 2014. So it uses hemovigil software for data tracking. Objectives are monitor transfusion reactions, educate healthcare professionals, provide safety recommendations, support regulatory decisions. Then there is National Blood Donor Vigilance Program, introduced in 2015 and launched on 14th of June. Aims to enhance donor care and encourage repeat donors, help strengthen the national blood supply, and hemovigilance enhances transfusion safety, prevents complications, and build public trust. So that is all from my side for today. And if there are any questions, comments, your experiences you wish to share or ask, you are most welcome to.
Take a Rudolph. Sir, good evening. You are not audible. Your mic is off.
Oh, I'm sorry. Yeah, go ahead, please.
Actually, I want to have two queries.
Yeah.
Like the blood components when you were discussing, no? I think you failed to mention about the platelets, which is very, very important. And there are two types of it: single donor platelets and random donor platelets. So that is one, and the leukodepleted blood components is also there. And nowadays, in fact, the whole blood is hardly used. They are these separated components which are being used in to save, because there will be unnecessary use of all the components where only packed RBC is required. There's no point of giving platelets or fresh frozen plasma. And you said there will be loss, you mean expiry of blood. It is always short, I am telling you. Whichever hospital I have worked, in fact, the colleges like RIMS, there is a long, waiting time also to get the blood. So it's not that easy. Another thing, my little thing about the screening of the blood, now the ELISA is almost out. They are doing it by chemiluminescence, means either CLIA or e-CLIA methods. So because ELISA was used on the based on the color, but where this is about the illuminations part, which is picking up, and that's it's more accurate. So these two things, in fact, came to my mind. That's why I wanted to talk, sir.
Good, thank you. So platelets are important and part of the different components also. So most commonly what we use nowadays is when it comes to providing the blood is the packed cell blood. So packed cell blood is the most common use, but you are right. The testing has also improved now, and it actually depends, because we are sitting in a tertiary care when we have the best of the equipments. But many of the smaller blood banks, they are still having
ELISA methods.
basic
But
technology, but they
but
have to follow
I'll tell you, sir. Now the blood banks are almost outsourced,
yeah.
and they have the best of the equipments.
Yeah. So they have to follow the basic guidelines that are there in the national policy, which is
Yeah.
being, strictly monitored and implemented. So they have to follow all those. So from administrator's point of view, and I have, you know, uh,
Bandita, you wanted to tell something? Bandita? No.
सॉरी सर, मैं ड्यूटी में हूँ सर, कोई आ गए, अभी उनसे बात कर रही थी, सॉरी।
Okay. Thank you. No problem.
I was telling you that I have faced a situation where the patient actually died after an alleged mismatched blood transfusion. So from administrator's point of view, what is most important is to be open with the family, to manage the situation and ensure and understand and do a thorough examination why this happened, where were the lapses, and how it can be prevented for future.
Quite right, sir. I'm telling you the practical experience of that barcoding being swapped with another patients, or the wrong blood being issued from the blood bank itself. This all everything I have seen and monitored also, and faced the public another where there has been hue and cry because of the wrong transfusions. The patients either becoming very serious or dying also. So this thing which you explained is really it's on the practical side. Wrong labeling, wrong cross matching, then wrong blood being issued to the patients. And if some of the by the God's grace, if some universal donor's blood is being issued to the other patients, even after the wrong cross match, then the patient survives. And for that we thank God also sometimes.
Yeah, so prevention is the best thing, and that's why the Swiss cheese model that I showed, that if it's checked at every level, the final person, whether it is a nurse or a resident or someone who is administering, does the checks to identifiers, and even if at multiple places, if the blood has arrived, it can still be. Let me tell you another incident in which actually the anesthetist in the OT actually prevented it. When the nurse was about to administer it, he actually thought कि मैं नाम पढ़ लेता हूँ. And there was a very slight, was similar sounding name was there, and a slight difference. And he said, no, this, and it was the transfusion was immediately prevented. It had not yet started. So even this was not the duty of the anesthetist, but anesthetist was vigilant. कि यार ये हो रहा है, मैं देख लेता हूँ, नर्स चढ़ा रहा है, क्या करूँ? So it was prevented. So it is everyone's responsibility. And if there are checks and balances in the system, then these types of errors or any type of error, whether it's a medication error or some other types of error, whether it's a diagnostic error or errors. For example, in MRI, you must have heard stories where patients were sent
Patient
inside.
getting sucked inside and dying. Yeah, because of the
They were
strong
having some
magnets.
metal on their body, or there was metal inside in some other form. So having checks and balances is very important. Thank you. Thank you for your inputs. Your inputs are always really valuable. Thank you very much.
Sir, we are really grateful. We are interacting with someone so knowledgeable, I'm telling you, and
And
receptive also to listen. So it's a pleasure interacting with you, sir.
thank
Thank
you.
you, sir. Thank you, sir.
Anyone else wanted to ask or share something?
Yes, sir. I have a question.
Yes.
Sir, sometimes donors will come and they try to hide about their medical history, like someone on any allergies and on his medication. And when he come, then she try to hide about the history. So what if he does the
See,
procedure?
see, if he has lied and still you have bleeded the donor, you will in any case going to do all the screening. So you will only be using that blood if it is fit to be used. So it is only will add to your wastage. That we do screening to prevent the wastage, right? That's screening is not a substitute to your testing. You're in any case going to do the testing and will find that if there is some high risk behavior was there, and if there is some patient already know that he is positive for some ailments or something. So in a screening, you will, if screening he has lied, it will be detected in the testing. So it only increases your wastage. For example, I was telling you, I once went to donation, tried to donate in United States, and they gave me an iPad, and I gave honestly all the answers. And at the end, they said you are not eligible to donate, and I was not sure why I was not eligible to donate. Then they said because you have come from a malaria endemic area, that is India. So we don't take blood of a person who has recently traveled from a malaria endemic area to US, because malaria is not endemic to US. So they refused to take blood from me. Had I not given them this information, they must have tested the blood for the malaria antibodies or whatever, and then it would have been discarded. So it is important that you give correct information.
Okay, sir, because it just happened is like small towns and small cities.
Yeah.
Because is there in private hospital is anywhere is needed. Just they said कि आप जाओ कोई भी blood group के ले आओ या just required any group of blood. So they just trying to कि कुछ भी दे दो and then take the required blood.
I
From
know.
the blank.
I know.
Yes.
I know.
But I'll tell you one practical experience, sir. I was working in as an army surgeon, working in JNK, where that time was peak of militancy also. So lots of ID blasts, gunshot wounds coming. And civilians were also treated in the border static areas where we were posted. So the moment there were a huge crowd of 100, 200 people. But when you say that the patient requires blood, most of them disappears. So ultimately, our army personnel were only our saving grace. We used to donate blood for those civilians also. So blood देने के नाम से तो बहुत लोग भाग जाते हैं सर, उनको बता देते भीड़ छट जाती है.
That's why we salute Indian Army, sir. That's why we salute you people.
Yes, sir.
Sir, one more question.
Yeah, please go ahead, Swati.
Sir, हीमोग्लोबिन बढ़ाने के लिए हम डायरेक्ट इंजेक्टेबल्स यूज कर सकते हैं। इन केस दोनों में कंपैरिजन ब्लड ट्रांसफ्यूजन या फिर इरिथ्रोपोएसिस, ये जो आईवी हीमोग्लोबिन बढ़ाने के लिए दिया जाता है, तो दोनों में कंपैरिजन व्हिच वन इज बेटर?
आपका कहने का मतलब है ट्रीटमेंट ऑफ एनीमिया आप बात कर रहे हो कि अगर एनीमिया है किसी को और हीमोग्लोबिन उसका बढ़ाना है, ये बात कह रहे हो आप?
हाँ सर।
नहीं देखो, ये तो क्लिनिकल डोमेन है. आई विल नॉट गो इनटू द क्लिनिकल साइड बिकॉज इट विल डिपेंड ऑन
I can explain, sir.
पेशेंट.
The blood का replacement blood ही है स्वाति, और erythropoiesis does not increase directly the blood count. What it works like, it stimulates your bone marrow so that the bone marrow start producing blood cells. And if you want to increase the hemoglobin gradually, then iron transfusion is available. And iron as well as the B12 and all those sort of injections, but that will increase along with the nutrition, but it's not in acute conditions. Acute conditions, blood replacement is blood only, or the blood components, not erythropoietin. Erythropoietin, you see, those things are in treatments are given to the chronic renal failure patients when required, or can be given in a general case, but it's not the normal practice.
नहीं, पहले ये स्वाति जी ये समझने की जरूरत है कि कॉज ऑफ, अगर इफ यू आर टॉकिंग ऑफ एनीमिया, व्हाट इज द कॉज ऑफ द एनीमिया? I mean, if the cause not necessarily be an iron deficiency, there are multiple reasons for anemia, and
Yes, sir.
identification of the proper cause, and then the treatment depends on the type of anemia. If it is an hemolytic anemia, if it is sickle cell anemia, or it is because of some other hemoglobinopathy, so that has to be seen, and the treatment will also differ based on the type of the anemia. So I will not say there is a straight answer to this, but as the Colonel Saab said, if it is a acute blood loss requiring a replacement of blood, that can only be done by a blood.
Okay, sir. Thank you, sir.
Thank you.
Good evening, sir.
Yeah, please go ahead, DM. Gee, what is your name?
Yes, sir. My name is Dao. I'm
Okay.
from Meghalaya. So, yeah, I have a background of MLT. I just have one question, sir, actually, regarding this one. How can we implement this near-miss reporting cultures, like among NICU nurses, without them fearing this punitive actions or administrative backlash, like regarding this hemovigilance and all?
Yeah, that's a very, very good question. And let me tell you, it doesn't have a straightforward answer because it's because we are humans, right? What we have tried in my previous organization also, where I was on deputation, is no blame culture. It starts where you start treating it at a system level. You look at the errors from the system's perspective and not from the individual's perspective. Individual just a component of the whole system. In the whole system, there is a responsibility of different people, but collectively there is a responsibility. So it's not a very straightforward answer that this will become in a day, but over a period of time, when they feel that you are working towards strengthening the system, you are providing the resources, you are open to feedback, you are making sure that adequate training and education is being provided, you are making sure that the SOPs are being followed, you are at the time also making sure that if there are violators, deliberate violators or non-compliant people, you are taking care of them also. You are not leaving here, okay, if these people are not doing okay, let it happen, because then it will become demotivating for others also. So it has to be a carrot and a stick both. Somewhere it is the carrot that works, and sometimes you have to use the stick also. Being firm, being at the forefront, when they have a problem they want to share with you and you are not available and you keep deferring it, then the trust and the confidence of the employee goes down. So employee one has the confidence that the employer has his back, then they are more forthcoming, and then more dedicated also. So I'm not sure if I have completely answered your question, but that is how it has to be approached.
Thank you, sir. Thank you for that answer.
Thank you.
I
Thank you
mean, I
for
do have one more sub
yeah,
questions
yeah.
regarding
Go ahead.
this.
Go
I
ahead.
mean, because this policy and the resource management that we are using more, like, what are the role that the blood bank should play in, directing, auditing the NICU nursing compliance with the hemovigilance guidelines, and how we can manage the interdepartmental, like, any frictions or breakdown, sir.
Yeah, transfusion medicine department is the actually spearhead, should spearhead all this. The whole, I would say, the institute's transfusion practices and the policies. So if any training is to be given to the nurses, so if you have a blood management committee, as I mentioned, or whatever the name of that committee is, they can actually, spearhead the whole program, do the training, find the gaps, do a gap analysis, find the practices that are not, in compliant with the policy, prepare the policy if there is no policy already, circulate it, from time to time, do the meetings, and then the important decisions that have been taken, they are circulated to the whole organization, reinforcing those decisions, having a mechanism for proper monitoring, having a proper mechanism of reporting of those errors within the organization and with the approval of the competent authority outside the organization also. Then the patient awareness also, as I mentioned, patient is a very important stakeholder. Many times they will tell you कि ये blood आ गया है पर इस पे नाम दूसरा लिखा हुआ है. I mean, if you understand Hindi, the blood has arrived, but this has the name of someone else before you actually transfuse. Or they will tell you something else, which they, because they are very vigilant nowadays. I have seen that the attendant are quite vigilant, and young people, when they come, they and they are genuinely involved in the decision making, which is a good in a way, in my view. So transfusion medicine department has an important role, and the office of the medical superintendent or the chief administrator, whatever the name in the organization is, have a role to facilitate what transfusion medicine department wants to implement. I know we should be facilitator to them. They will be the ones who will be implementing, coming up with ideas. For example, I remember in my hospital some time back, the faculty of the transfusion medicine, I used to look after the indoor area at that time. They said, yeah, Mahesh, what is happening is that the JRs in the surgical departments are, have become kind of hoarders of blood. They are, keeping a lot of blood which is not required. So we said, okay, what should be done? They said, okay, just allow us that one of our person will go and periodically and every day will take a round and check, and where there is a blood in the refrigerators, additional blood, give us the power that we will collect it and bring it back to the ground. Yeah, okay, go ahead. So we are the facilitators. So whatever is needed, and then it helps the system when we are seen as a facilitator rather than the road blockers.
Yeah, thank you, sir. Actually, I do have one more supplementary question
Yeah.
regarding
Go ahead.
this
As
one.
long as no one else has a question, I don't mind. Go ahead.
Yes, sir. Actually, regarding, like, suppose in India, we in Meghalaya, especially in my state, we do have blood centers and all, and blood storage unit area. But in those center, or where in the storage area, they have very less of blood transfer. I mean, the blood storage and all. So even the programs and all, it's not regular.